Imagine going to buy a brand new car.
Okay.
You walk into the dealership, write a check for $37,824, hand it over.
And you don't get a car.
You get the privilege of knowing that if a massive catastrophe hits your family this year, you might not go bankrupt.
Which is the point. That $37,000 figure is the reality for the average family in 2026.
According to Axios, that's the average annual healthcare cost for a family of four under employer-sponsored coverage in 2026.
And people look at that and think, how are we spending this much when it feels harder than ever to get an appointment?
You're not imagining it. The math validates the frustration.
So today we're pulling from the SWFT Healthcare Intelligence Brief for the week of May 18th through the 25th, 2026. 3 themes: the illusion of affordability, AI as an administrative gatekeeper, and the upstream turf wars over the healthcare dollar.
Let's start with the cost shifting because that's really the spine of the whole thing.
All right, if a family plan costs nearly $38,000 a year, how is the employer carrying that?
By carrying it in a way employees don't always see. Employers can't just double premium deductions without a revolt, so they absorb the inflation elsewhere. Wage growth slows, raises disappear, hiring freezes.
So it's an invisible tax.
Exactly. You think you've got a good benefits package, but part of the cost is coming out of your stagnant earning power.
And if you don't have an employer buffer, if you're buying coverage yourself, the numbers are much more obvious.
Right. The KFF analysis in the brief says the average Affordable Care Act marketplace deductible jumped 37% to a record $3,786.
That's a big number. It means a lot of people are on the hook for nearly $4,000 before insurance starts doing much.
And the brief says part of what's driving that is healthier consumers leaving the market.
Which sounds technical, but the mechanism is simple. Insurance works when healthy people pay in and don't use much care.
Right, but once premiums get high enough, younger and healthier people start doing the math. They drop coverage or move to very cheap, very thin plans.
So the remaining pool is sicker and more expensive.
And if insurers can't sharply raise premiums, they squeeze somewhere else. So deductibles rise. That's the cycle.
Then CMS tries to patch the system. The brief says CMS finalized a rule for 2027, expanding access to catastrophic ACA plans.
Which sounds like relief if you're staring at a monthly premium.
But the word catastrophic matters. These plans are there to protect against total financial ruin, not routine care.
That's it. Lower premium, yes. But for day-to-day needs, not much help. Bad sinus infection, twisted ankle, physical therapy. You may be paying out of pocket.
It's the cheap umbrella that only opens in a Category 5 hurricane.
Pretty much. And in healthcare, when the out-of-pocket burden gets too high, people don't just get mildly inconvenienced, they delay care.
They skip the cough, skip the follow-up, skip the routine visit because they know it'll cost them.
Then the problem gets worse and shows up later in a more expensive setting. So the cost didn't disappear. It got delayed and shifted downstream.
That's the illusion of affordability. Employers freeze wages because they can't absorb the family plan cost forever. Patients flee into catastrophic plans because they can't absorb the deductible. Same problem, different layer.
And when the system starts running out of room financially, the corporate answer is not, let's hire more doctors. The answer is, let's automate administration.
Which gets us to AI. The brief is not talking about sci-fi medicine here. This is administration, communication, and payment control.
Aetna, for example, is heavily deploying AI for member engagement.
Meaning automated navigation and communication between the patient and the insurer.
Right. Then there's a bridge, which the brief says hired a new tech chief to scale ambient AI.
That's the exam room tool. The AI listens to the visit and generates documentation.
And from the clinician side, that's being pitched as a major win because of what everybody now calls pajama time.
Meaning the hours after clinic when doctors are home typing notes into the electronic record.
Which is a real burden, and burnout is a real crisis. So yes, Ambient AI could reduce documentation work.
But here's the skepticism. If an AI captures every word of a 15-minute visit, is it only saving time? Or is it also becoming very efficient at finding more billable diagnostic codes?
That's the issue. Coding intensity. A human clinician might document the sprained wrist and move on. The AI doesn't forget the headache, the rash, the side comment,
It catches everything.
and everything can become a code. So while the doctor may save 2 hours at night, the total cost of care may rise because every billable detail gets captured.
Which triggers the obvious arms race. If providers use AI to maximize billing, payers will use AI to block it.
Exactly. That's where the CMS Wiser model comes in. CMS is trying to use AI for prior authorization in original Medicare to flag and reduce what it describes as wasteful spending.
And the brief says Senate Democrats are moving to roll that back. Quick pause here. We are not taking political sides. We're just reporting the brief and talking through the mechanics.
Exactly. Same with the Trump administration item we'll mention in a minute. This is policy mechanics and market impact, not politics.
So why would lawmakers oppose an AI tool that's supposed to catch waste?
Because of the automated bouncer effect. Prior authorization already means doctors ask permission before certain procedures or expensive drugs. If a human does the review, it's one thing. If an algorithm does it, denials can happen in milliseconds.
And the fear is that it becomes an opaque algorithmic gatekeeper, fast, efficient, and wrong.
Right. You get the doctor's AI trying to optimize documentation and the payer's AI trying to optimize denial. The patient sits in the middle.
The brief also says HHS is launching an AI-backed crackdown to audit federal and state grant recipients for fraud.
Which shows the broader pattern. AI is becoming payment control infrastructure. It may reduce fraud and administrative waste, but if the rules live in a black box, the patient can be left stranded while systems fight over codes and approvals.
So if AI is becoming the tool that controls the money, who is fighting over the money itself?
That's the upstream part. And those battles are happening in courtrooms and boardrooms.
The brief starts with hospitals suing CVS over an alleged $250 million in lost savings tied to 340B specialty pharmacy economics.
For anyone who doesn't live in this world, 340B is basically a mandatory discount structure. Drug manufacturers sell certain expensive specialty drugs to safety net hospitals at a steep discount if they want coverage through Medicaid and Medicare.
Because those hospitals care for a lot of uninsured and low-income patients and need that margin to survive.
Right. But many hospitals don't have their own big specialty pharmacies. So they use outside contract pharmacies like CVS.
And CVS isn't just a pharmacy, it's vertically integrated. Pharmacy, pharmacy benefit manager, insurer, the whole pipeline.
So the hospitals allege that CVS used that market power to change reimbursement rules and capture the 340B margin themselves.
In other words, the hospital's financial lifeline gets siphoned off by the middleman. That's the allegation.
Yes, and hospitals are also under pressure from government policy. The brief says the Trump administration is proposing a crackdown on Medicaid state-directed payments. Again, no politics here, just the financial mechanics.
State-directed payments are one way states send extra federal dollars to providers because Medicaid reimbursement is often below the cost of care.
So hospitals depend on those supplemental payments to keep the lights on, limit them, and safety net hospitals take a real hit.
And hospitals don't just quietly absorb that, they shift it.
Exactly. Same basic logic as a restaurant losing money on lunch and raising dinner prices. In healthcare, if hospitals lose money on Medicare or Medicaid, they go to commercial insurers and demand higher reimbursement.
The insurers pass that to employers, employers pass it through frozen wages or thinner plans, and now we're back at the opening number.
It's all connected.
Independent physicians get squeezed in the middle of all this. The brief says many practices are facing such intense strain from prior authorization, low reimbursement, and administrative overhead, the AI bouncers, if you like, that they're going bankrupt or selling.
And House lawmakers are considering physician payment reform to try to slow that trend.
Because when independent practices can't survive, they sell to hospital systems or private equity groups,
which drives local consolidation. And once one giant system owns the clinics and specialists in your area, it has real leverage with insurers.
The brief does add one interesting complication, though. The HHS Office of Inspector General looked at pharmacy benefit managers and found limited evidence that PBM vertical integration directly raises Medicare drug costs,
which complicates the usual story. For years, the assumption has been that owning the insurer, the PBM, and the pharmacy all at once is a main driver of drug pricing. The OIG says the evidence for that is limited, while also noting the data are incomplete.
So simply breaking the companies apart may not solve the problem.
Right. The brief points to the underlying contracting mechanics instead, especially spread pricing and rebate flows.
Walk through spread pricing.
A PBM sits between the health plan and the pharmacy. Under spread pricing, the PBM might charge the health plan $100 for a generic blood pressure medication,
but only reimburse the pharmacy $10.
And keep the $90 difference.
That's the hidden margin.
Exactly. So the OIG report suggests that if policymakers want lower drug costs, just attacking the org chart may not be enough. You'd have to address spread pricing and force transparency on rebate flows.
So what's the big takeaway from all of this?
That the most important fights in healthcare are no longer mainly about the physical delivery of care. They're about control of the infrastructure.
Meaning reimbursement rules, payment oversight algorithms, pharmacy contracting. Who controls the systems behind the visit?
Exactly. The competitive advantage has moved upstream.
And the recap is pretty stark. We started with that $37,824 employer family cost and the $3,786 ACA deductible.
Then the so-called affordable catastrophic plans, which don't remove cost, they shift risk to the patient.
Then the AI arms race. Providers using AI to maximize coding intensity. Payers using AI as an automated bouncer.
And finally, the turf wars, hospitals, PBMs, pharmacies, and government policy all fighting over shrinking margins, while independent doctors get pushed towards selling and costs keep moving back to the public.
It's a complicated system, but the pattern is pretty plain. The financial misdirection is everywhere.
And one final thought. If control of healthcare keeps moving into data, artificial intelligence, and financial infrastructure, what happens when the corporation controlling your health data knows more about your financial breaking point than your doctor knows about your physical health?
That's the uncomfortable question.
And that's why we do this.
Thanks for joining us. Keep asking questions. We'll catch you next time.